So just to warn you, there's a lot of material in this section. This is about 4 hours worth of material. So you need to plan on plenty of time to watch all these videos when you have time to digest them. If you try to watch them all back to back, if you try to speed them up, you're not going to get all the information you need. This is a lot, but it is not as hard as it looks. You have the building blocks to be able to understand what we're going to talk about in this lecture. In class, we're going to have a couple hours, and we're going to do some activities to help you understand better the disease processes we're talking about. So I know that a lot of you are going to be intimidated about this material, and I just want you to take your time, make sure that you understand it. So that means you need to start early enough preparing for this. So we're going to begin with assessment, cardiovascular assessment in children, and we're going to start with history. One of the things that I would want to know is what concerns do the parent have that prompted the visit? Is their child having, what kind of things would make you think there might be a cardiac issue? So is the child having syncope? Are they having episodes where they faint? Have they had an episode where their color was not right? They were cyanotic or pale. Are they complaining of chest pain? Are they complaining of feeling their heart race or pump really hard? So what concerns do the parents have? And beginning with that, you can start to have an idea of what other questions need to be asked and what things need to be assessed. You want to know family health history. Are there any known hereditary heart conditions in the family? If a family member has a congenital heart defect, it's more likely, or when a child has a congenital heart defect, it's more likely that other family members will as well. We also would want to know, is there a history of unexplained child or infant deaths or stillbirths? Because those can also be connected to congenital heart issues. We want to know about pregnancy and birth history. During the pregnancy, did the mother have diabetes or lupus? Because those are associated with heart defects. Did the mother take any medications that are associated with potentially congenital heart defects? Were there any exposures to chemicals or to drugs that may have an effect on the development of the heart? There are specific infections like rubella that cause congenital heart defects. And was the infant small or large for gestational age? Because both of those can be a symptom of a congenital heart defect. We want to know about the individual health history. There are some chromosomal anomalies that are associated with heart defects. Down syndrome in particular, Turner syndrome is also associated with a higher risk of congenital heart defects. Has the child had any history of unexplained loss of consciousness, apnea, where they just stop breathing, pallor or cyanosis? Does the child have a heart murmur? Now, one thing about heart murmurs is sometimes you hear them, sometimes you don't. There may be a murmur that's there all the time, or there may be a murmur that's intermittent, that sometimes you hear, sometimes you don't. And there are children with heart murmurs who have no cardiovascular issues, and some very significant cardiovascular issues do not cause a murmur. So murmur is not the only consideration. We tend to kind of get hung up on it, but if they have a heart murmur, it needs to be followed up on. Now, physical assessment, when you look at the child, in general, what is your impression of their nutritional state? Are they gaining weight and growing appropriately? Failure to thrive can be because of a heart defect. Are they blue or pale? Cyanosis or pallor can be due to the heart. Do they have visible chest deformities? When you look at the chest, is the shape typical? Do they have any unusual pulsations? Can you see a visible pulse in a place that you shouldn't be able to? Respiratory effort. Dyspnea and difficulty breathing is very common with cardiac problems, either because they can't get enough oxygen into their blood, or because they have fluid in their lungs from CHF. With chronic hypoxia, we might see clubbing of fingers. So I want you to think about, you're assessing a child, what kinds of things are going to make you think, I should consider maybe there's a heart problem here. Okay. Palpation and percussion, we would palpate for the heart size and location. We might, for where we can, they might percuss for that. We're going to palpate for where we can feel the heartbeat, point of maximum impulse. We palpate for hepatomegaly. If the liver's enlarged, that can be due to heart failure. We palpate peripheral pulses. Are the pulses all as strong as they're supposed to be, where they're supposed to be? And we palpate for an abnormal thrill. If I want you to imagine water flowing through a pipe, and then if there's a spot in the pipe where there's, it's malformed, maybe it's got a little lump on the inside, what's that going to sound like? That may be we may hear we may feel a thrill. What's that going to feel like? We feel that vibration because the path is rough. Okay. Or think about how a creek flowing over rocks gets rougher and noisier. Auscultation, we're going to listen for the regularity of the rhythm. We want to auscultate an apical heart rate on any child under 3 and any child with a suspected heart condition. Apical rate for a full minute. So we want to compare that rate to the normal rate for that child's age. If you don't do peds all the time, you may not remember that. Go look it up. It's not hard to look those things up. And we want to listen for the character of heart sounds. Do we hear just a loved up, or do we hear a softer sound as one of those? That's a murmur. Or do we hear any extra sounds? Is it? Okay. Think about, are we hearing just S1, S2, or are we hearing a different sound, or is one of those sounds softer than the other? Some diagnostic testing that might be done. You have dealt with EKGs on adults. Kids can have EKGs. An EKG measures electrical activity. It does not measure whether the heart is contracting or how strong it's contracting. You can have normal electric activity or abnormal electrical activity without a heart beat, without pumping. So an EKG measures the electrical activity and allows us to identify anomalies, but it doesn't guarantee that the heart is pumping effectively. What would you expect to be an issue if you've done an EKG or observed an EKG in clinical? What would you expect to be an issue with a 3 or 4-year-old? So to get an accurate reading, we have to be still for just a couple of minutes. Doesn't take a really long time. So a 7 or 8-year-old should be able to do that, right? But a 2 or 3-year-old may struggle to be still long enough to get a good reading. So you want to think about how you're going to deal with that. Are you going to try distraction? Are you going to get them interested in watching a show on a phone or tablet? What can you do to keep them still long enough to get a good reading? Echocardiography uses ultrasound to produce an image of the heart structure. So if there's a suspected anomaly or heart issue, then an echo is very common. Echoes are non-invasive. They do not hurt. If they're done transcutaneous, they're non-invasive and not painful. But again, they have to be really still in very specific positions to get good images. So older kids might be able to be distracted, but small kids might actually need to be sedated to be able to keep them still long enough to get a good echo. Transcutaneous means it's done through the skin. They actually can use a scope and do a transesophageal echo. That, of course, is going to be a little bit more invasive and more uncomfortable, but it allows better imaging of certain parts of the heart. A cardiac MRI, you know what MRI is. It creates an image using a magnet. It can be used to look more specifically at anatomy, to assess blood flow, and to assess myocardial perfusion, how well the heart muscle itself is being perfused. It's also non-invasive, but it requires lying still for a prolonged time, often enclosed in a really small space. So claustrophobia is very common, and no metal can enter the room with the magnet at all. Again, think about small child. What are you going to be doing? You're taking someone to MRI. They have an IV. What are you going to do? If they can't walk, how are you going to get them into the room? So I want you to think through all of those potential issues with each one of these. Cardiac catheterization is an invasive procedure, but it's often done for kids and young adults with some specific cardiac issues. It can be diagnostic. They can use that cardiac cath to diagnose what's going on. It can be therapeutic. Some things can be fixed with that, or it can be both. So how is it done? A radiopaque catheter is introduced into a large artery and guided to the heart using fluoroscopy. Once it's in the heart, that catheter can be used to measure things, to take images, to inject contrast, to look at circulation, to directly measure electrical impulses. There are some interventions that are possible. It can be used to patch openings and make some corrections. It can be used to dilate some valves or vessels. So there's some intervention that can be done. Cardiac cath is what they do to place stents when someone is having a heart attack or at risk for heart attack. But there are some other things that can be done with that cardiac cath. What are the risks? This is an invasive procedure. So I want you to think about, don't look at the risk list yet. I want you to get a piece of paper and write down the things that you think might be a risk of the procedure I just described. They use a large needle to put a catheter into a large artery, and then they use fluoroscopy to guide that catheter to the heart. Okay, so I want you to think about the things that might cause. What might the risk be? And pause for just a minute and make a list. Okay, let's compare lists. Hemorrhage, obviously, we're puncturing a large artery. Infection, because we're poking a hole that doesn't belong there. Exposure to radiation, because this takes longer than a simple x-ray, so there's some radiation exposure. Arrhythmias, because we're messing around in the heart. Young infants can become hypothermic because of the time that it takes, that they have to be partially uncovered, but also we're putting something into them that's going to lower their temperature. That artery can become obstructed. The contrast medium that's used may trigger an allergic response. The contrast can also be really hard on the kidneys. I don't know if any of you have had a patient who was scheduled for maybe a CT with contrast and they had to look at creatinine first, because the contrast can injure kidneys if they're already at risk. They can have direct injury to the heart. We're sticking a foreign object into this child's heart. They can have central nervous system injury, like a stroke, because it can trigger an embolus or a spasm that can cause loss of perfusion or death. Now, those stroke and death are pretty rare, but they are possibilities when someone's doing a cardiac cath. The reason that this is done is because it's lower risk than open heart surgery for some of those corrections, but they really sometimes need the very specific information that they can get. So to care for a child who's having a cardiac cath, a child or an adult, there are some things that we have to do. Okay, pre-procedure, as the nurse, you need to get that child's current height and weight. Don't go by what the parents tell you. They need a height and weight that determines the size of the catheter. Do you need to know what they're allergic to so that they can make sure the contrast is not likely to trigger allergy? Do they have a pre-existing infection? So if I have an infection in, let's say I have an infected tooth, okay, I have an abscess tooth, and someone puts a hole in one of my arteries and puts a foreign body into my body for, 2 or 3 hours or less, maybe 30 minutes, depending on what they've got to do. Okay. The bacteria from that infection, if they get it, if they're in the bloodstream, they can actually set up a new infection at the location where I'm irritating the blood vessels and the heart with that foreign body. So any pre-existing infection, even a diaper rash, can mean that this procedure gets pushed back. We want baseline O2 sats and peripheral pulses. We want to know that below the place where they're inserting that catheter, historically they used to use the femoral artery a lot, so we would be doing what pulses for that. We would want the posterior tibial and the dorsalis pedis. Okay, so we want distal to that. Now, sometimes they're using the brachial. So if they're using the brachial artery, we want to make sure that they have radial pulses, right? So we want to assess their peripheral pulses, and then we want to mark where they're most easily felt. So if there's a question after surgery, they can quickly assess. Okay, we want to do teaching. We want to make sure that we're giving age and developmentally appropriate teaching for the child. So an infant, that's going to be to the adult, right? But a toddler, we're going to give them some information right at the time it's going to happen. We don't tell them 3 days ahead of time because it doesn't have much meaning for them. So right at the day it's going to happen, then we tell them what we're doing. But we tell them, what would you tell a toddler or preschooler? We're going to tell them we're going to take images of your heart so that the doctor knows if you have a blah, 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 whatever congenital defect. No, because that has no meaning for them. We're going to say the doctor is going to make an owie, put a needle into your arm or your leg, wherever it's going to go. And they're going to use that. They're going to put something inside, put a camera inside and take pictures. And then they're going to take it out and we're going to cover up the hole so that it can heal. Okay, so think about what the child is going to experience, not the medical side. As kids get older, they understand more, they have more questions, but we want to make sure we're doing developmentally appropriate teaching. Older children, we want to explain the procedure, still focus on what they'll experience. Adolescents may have a lot more questions about risk. And then parents, we want to make sure, parents and adolescents, we want to give them a full explanation of what's happening. Sedation or anesthesia. We need to make sure that they understand what kind of sedation or anesthesia is done or needs to be done. That's determined based on the child's age, their health status, and how stable they are, how well they're able to cooperate, and the type and length of procedure. It may be done by IV sedation. Make sure that you are familiar with hospital policy and the Nurse Practice Act if you are asked to administer or monitor conscious sedation. General anesthesia may be used especially for children because they have a harder time being still long enough, and especially if they're doing interventional rather than just assessment. They are probably going to be NPO for 6 to 8 hours before the procedure, so they may need IV fluids. So now, during the procedure, your role would be as a circulating nurse or scrub, right? Post-procedure, they're on frequent vital signs. We're monitoring their vital signs very closely. Heart rate for 1 full minute, pulse ox frequent on the frequent vital sign schedule. Every time we do vital signs, we're also checking for pulses, color, sensation below the catheterization site. If they're using the femoral site, which is more common in kids, especially smaller kids, that means checking their toes, checking their pedal pulses. If they're using the brachial site, we're looking at fingers, radial pulses. We observe the dressing. There's a pressure dressing that's going to be put on the site, and we observe that for bleeding. Because bleeding will be very, very rapid if it occurs. We monitor their fluid status, blood glucose. Position limitations are based on hospital policy, but typically, if they actually can do this using veins. They more often are going to use an artery, but typically they have to keep from disrupting that site for 4 to 6 hours for venous, 6 to 8 hours for arterial. So that means keeping that kid laying down flat for 6 to 8 hours. Resume diet is tolerated. Encourage fluid based on the child's status. Some kids don't need as much fluid. Encourage voiding and protect that wound from contamination. The last test I want to talk about is BNAP, and you're familiar with that because you've taken care of adult CHF patients. Adults should be less than 100. The use of this in children is much less established. You're most likely to see it used by cardiologists who are familiar with it, but you need to know that the normal value is different based on age and size. Okay, we're going to take a break. In the next section, we're going to start talking about congenital heart defects.